are going to cover the second part of the thyroid disorder. Let me share files. Okay. Right. So today we'll cover, inshallah, we finished yesterday the functional disorder with that hypo, hyper, or even inflammation. We'll cover structural disorders. Like what the structural disorder can be goiter, can be thyroid nodules, and at the end we cover just a few information about thyroid cancer. Let's remember the anatomy of the thyroid. It's just going to help us now in the clinical feature. Normally thyroid gland is about 4 centimeter in size in 2 dimensions, so it's a small gland. And the mean volume is 7 to 10 ml. It weighs 10 to 20 grams. The thyroid is bordered superiorly by the larynx and posteriorly the trachea and esophagus, and the carotid sheath bilaterally. What is goiter? Goiter is abnormal growth of the thyroid gland, so abnormal growth, and it can be diffused or nodular. So diffuse goiter we call it, or nodular goiter. So this is a patient with solitary nodular goiter, so thyroid nodule, and since it is enlarged, so it's called goiter. This is an extreme case of diffuse thyroid enlargement, and actually it's due to iodine deficiency, very huge, not managed well with thyroxine. That's what happens. So that's a diffuse goiter, that's a nodular goiter. What causes goiter? What causes the abnormal growth of the thyroid gland? Iodine deficiency is the most common cause of goiter worldwide and generally. Initially, it diffuses and then it becomes nodular. And the reason is the low iodine intake leads to reduced T4 and T3, resulting in increased TSH. The high TSH stimulates the thyroid growth, then goiter happen as a part of compensatory response to the iodine deficiency. But in countries with iodine sufficient areas, that does not exist, so the most common cause of goiter, if it's there, is multinodular goiter, especially in older patients above the age of 50 and so. And the more advanced age, the more multinodular goiter will be seen. It's still not known mechanism, but it has been postulated to be several growth factors involved, some genetic causes, and presence of family history. Hashimoto thyroiditis can present in 2 forms, if you remember. It can be goitrous or atrophic. And the reason if there is a goiter and Hashimoto thyroiditis due to the level high secretion of TSH and enhances the thyroid growth. Graves' disease is a common cause as well of goiter in hyperthyroid patients. So in hypothyroid patient, Hashimoto thyroiditis. In hyperthyroid patient, the Graves' disease. And most of the time, if the patient is euthyroid, the multinodular goiter, or in iodine deficient areas, iodine deficiency. This is another table for many reasons. So that the one I told you is the most common ones. Other causes of goiter in adult we cover. So they put here multinodular goiter first because that's the most common one in iodine sufficient areas. And then iodine deficiency worldwide. Then autoimmune causes, whether Hashimoto or even thyroiditis. Ingestion of goitrogens. There's some food or medicine can be taken, increases the thyroid growth. The presence of, so let's say now you say, why is iodine, if the iodine deficiency can cause goiter? The high level of iodine. I had a patient, was it last week? He was taking something from iHerb. It contains iodine. So he was taking it regularly and it was high dose and he came with a thyroid nodule. So presence of high iodine can cause goitrogen, like high level. Lithium, we mentioned that, can cause hypothyroidism and also can cause goiter. Certain food like cassava, millet, broccoli as well, cauliflower in large amount, not just a simple millet دخن. So if you have that smallly with the dates, it's okay, but large amount with millet of cauliflower will cause goiter. Infiltrative disease like thyroiditis, that's a IgG4 disease, amyloid or histiocytosis or sarcoidosis. So any infiltration with inflammatory process. If it's toxic, either Graves' disease or toxic nodules. Sometimes a thyroid cyst, thyroglossal duct cyst, it's above the level of the thyroid, or thyroid adenoma. So any thyroid nodule, if it's an adenoma, benign nodule, or if it's a malignant nodule, it presents with goiter. So how patient with goiter will present to you? They can be most of the time asymptomatic, especially if it is a small thyroid nodule, if it's a nodular goiter, or it's a small one, or it's found only by physical exam, or found incidental or cross-sectional imaging. Most of the patients referred like they had MRI of the cervical spine, then they found thyroid nodules. In this case, I wouldn't call it goiter yet because it's not, if it's not palpable in exam, so maybe just like a incidental thyroid nodule. They can present with neck swelling, and that's the most common presentation. They come that I have neck fullness, I have lump in my neck, or presence of obstructive or compressive symptom, obstruction to the adjacent structure and compression to the adjacent structure. Obstruction or compression on the trachea can cause dyspnea, especially by and triggered by lying flat. A stridor or wheezing if the pressure on the trachea was more to a level that causes the tracheal diameter less than 5 millimeter, less than this diameter, then they will present not just for dyspnea but also with stridor or wheezing. Dysphagia if it's compressing on the esophagus. Cough can be present in 10 to 30% of patients. So it's a high percent, so it's a very common presentation to cause cough. Hoarseness from compression on the laryngeal nerve, that's more if it's thyroid cancer, it's infiltrating the adjacent nerve, and the most one does this is a thyroid cancer. Horner's syndrome due to compression of the cervical sympathetic chain, and that lead to ptosis, meiosis, and anhidrosis. Again, if it's a very large goiter, or if it's a thyroid cancer and invading the adjacent structure. Compression on the jugular vein, or even thrombosis. So jugular vein compression or thrombosis, or even lower than the jugular vein on the superior vena cava by causing superior vena cava syndrome, Pemberton signs. Or even it can grow posteriorly down to the retrosternum and cause tracheal deviation. And also you need to examine the patient for facial appearance of hypothyroidism or Graves' disease to help you narrow your differentials or the cause of the goiter. Okay, remember, this is the facial appearance of a patient with hypothyroidism, dull face, dark, dry skin, and thickened skin, and edema around the eyes. And this is a patient with a Graves' disease. I can see in this patient she has exophthalmos, periorbital edema, Graves' ophthalmopathy. You may not notice that much of goiter on her here, but there is also here a tibial mixed edema, which is feature of Graves' disease. Look at this patient. There is acrobacy, clubbing of the fingers with swelling of the clubbing of the nails and swelling of the fingers. And see this patient, she has a Graves' ophthalmopathy, and also you can notice the goiter. Again, this patient too, she has mild to moderate goiter, but you can see the Graves, what's called the Graves look. Okay, what is the superior vena cava obstruction or Pemberton sign? It's you need to elicit this sign by asking a patient to raise your hands or your arms, above your head By narrowing, you are narrowing the thoracic inlet, and if you narrow that and the space already narrow from the large goiter, there will be facial congestion due to blockage of the jugular vein and superior vena cava. Is it only in goiter? No, it can happen in any thoracic inlet tumors, like Bancost tumors or lung tumors. So anything that narrow the thoracic inlet. Horner syndrome we mentioned. So what do you think, which eye does have Horner syndrome? This is the right of the patient and this is the left of the patient. Let's see, left, yes. So this is the right of the patient and that's the left. You can see ptosis, meiosis, look at the pupil, this is smaller. We cannot tell about anhidrosis, but you can see the ptosis and the meiosis compared to the right. So you need to examine carefully the left loop. Another thing is also to auscultate the thyroid loop by listening to what's called a thyroid purvey. In a Graves' disease, the hypervascularity within the thyroid can be audible, and that's called thyroid purvey. If you want to also check for retrosternal goiter, check for retrosternal dullness. Usually, if you do sternal coming from the trachea down, you will hear resonance. But if there is a dullness, that means the goiter is extending inferiorly. So you better cast downward from the sternal notch. Okay, so all right, there is an answer on this. I did not share the screen. All right, never mind. When you see this chest X-ray, we see widening of the mediastinum. Can you see that? The dotted line. And the trachea is deviated due to the downward growth of the thyroid. So the trachea is shifted to the right and the upper mediastinum is wide due to retrosternal goiter. Okay, same thing. This is a CT scan for same patient with a retrosternal goiter or substernal goiter. So this is the goiter. Normally, we don't see thyroid in the chest and the chest X-ray or on the CT chest. The thyroid in the neck, not in the chest. So it's abnormal to see the thyroid structure behind the sternum. So that means that this is a retrosternal goiter. And we can see that it is pushing the trachea. So the trachea here is less than 5 millimeter. So we need to examine this patient for stridor, monitoring the airway, and also the esophagus is being pushed. So those patients might suffer from dysphagia, difficulty swallowing, and even difficulty breathing, especially when they lie down flat. How do you approach patient? If a patient comes to you with a history, so you need to ask about history about the presence of these symptoms of compressive or obstructive symptoms. Do you have any difficulty swallowing, any changes in your voice? Do you have any difficulty breathing, especially when you lie down flat? Any symptoms or signs of the hyperthyroidism or hypothyroidism? We covered that already yesterday. Then you move on to your physical examination to differentiate between is it diffuse goiter or is it just a thyroid nodule. And you need to look for the signs of obstruction by eliciting Pemberton sign, look for the eyes, look for retrosternal dullness, and you need to do a general physical exam in order for looking for symptoms and for signs of hypothyroidism or hyperthyroidism. You have to look for the facial appearance, the eyes, look for the tremors, the pulse, signs of erythema, and so on. We have discussed in detail that yesterday. After you've After your history, after your physical, the first important thing to do is the thyroid function test, especially the TSH, and we'll come to why that. And then we do the imaging, especially if it's not done as an incidental. Either you do an ultrasound, and ultrasound is the best to see the thyroid structure, so the ultrasound is the best, and mainly to assess for the goiter size and presence of the nodules. We can do the CT neck or CT chest. We always need to, in the neck and the chest, to look for the retrosternal goiter. In the end, we might, not all the cases, we might need a nuclear uptake and scan if we are suspecting a toxic nodule or if we are suspecting a Graves' disease. So only if the TSH is what, high or low, we'll do the nuclear scan, or normal. So question, I think you're not hearing this as a question. In what cases you will do the nuclear scan? So we took history, you did physical exam, this patient has a goiter, and then you did an ultrasound, you found a thyroid nodule or diffuse enlargement of the gland. And then when do I decide, so I don't know if this is answer for that, when do I decide if this patient need a nuclear scan or not? What level of the TSH will help me to do the nuclear scan? Uptake is more, Graves high, nodular. No, my question is, what is the level of TSH low? Okay, suppressed TSH below the normal range will do the nuclear scan. Not less than 5. Less than 5 is still within range between, because the normal between 0.5 to 5. No, below that, suppressed TSH. Yes, suppressed low TSH. That means there is hyperthyroidism. Okay, if I'm suspecting, let's say, if I am suspecting pituitary central hyperthyroidism due to TSH adenoma, is the nuclear scan of a value ولا لا? Will the nuclear scan help me ولا لا? No, then what's going to help me? MRI of what? FNA never for someone with hyperthyroidism. Pituitary. Yes, pituitary MRI, because the TSH can be, if the TSH is normal or high and the patient has picture of hyperthyroidism, I don't want to do nuclear scan. Of course, it's going to be high. I will do pituitary MRI. Excellent. All right, so this is an ultrasound of the thyroid. This is the trachea, and we have the right lobe, isthmus, and the left lobe. We can see there is a nodule within the left lobe. So the gray homogeneous color is a normal thyroid. Once it changed, then there is a halo, is a thyroid nodule. So let's talk about thyroid nodules. Thyroid nodules can be classified according to its function or structure by the ultrasound. By its function, like is this nodule is functioning, producing thyroid hormone, so it's called toxic or hot nodule, or it's not functioning and it's not producing extra hormones, so it's called cold nodule. Or we can classify it according to its appearance on the ultrasound, like solid nodule, cystic, or complex nodule. So let's come to the definition of the thyroid nodules, the functioning thyroid nodules, according to the function. If I have a functional thyroid nodule, the other name is called toxic. Why toxic? Because it produces extra thyroid hormone. So what would be the lab on this toxic nodule? So it is a form of a primary hyperthyroidism. So the TSH will be low and the thyroid hormones will be high or normal if it's subclinical. And if I do the nuclear scan, it will appear hot. How is hot? That it takes all the iodine and the rest of the gland decreased because it took it all for herself. The rest of the gland is not normal uptake, it's decreased uptake due to this toxic. That's why it's called toxic. It takes everything for herself. The other nodule is the non-functioning or non-toxic cold nodule. Those patients, they will have either normal or high TSH, so away from hyperthyroidism. Sometimes those patients, they will have another patient, let's say another example, a patient with low TSH and the nodule is not the reason. So they have low TSH due to a Graves' disease, okay? But they have a nodule on the ultrasound or on exam. How I know that this nodule is not the reason for the low TSH, it's a cold nodule. Again, when I do the nuclear scan, this nodule will not take the iodine, okay? So that's a beer cold, that's what's it called, cold nodule on the nuclear scan. So that's why it's called cold nodule. Due to low uptake, yes, it will not take it. The low TSH then is not this nodule is not the cause of this hyperthyroidism. Why I care, why we do that, we'll see why. So I mentioned earlier also that we can classify the thyroid nodules according to its structure by the ultrasound. So the most common ones, it's more than this, but I just brought it simple for you. Cyst, it can be as a cyst. So cyst is just a fluid, a bag of fluid, and this is usually benign. It appears black on the ultrasound. So this is the thyroid structure, and the cyst is a black, very black, it's called anechoic on the ultrasound. And we don't do biopsy for this. Cyst is benign, we don't do biopsy. The reason we do biopsies for thyroid nodule is to exclude what? If I see a lump in the body, I go and do biopsy. Malignancy. We need to rule out thyroid cancer. So cyst is usually benign. So assuring the patient we don't need to biopsy this. Everything is gonna come out will be fluid and colloid. The other form is the solid nodule. There are different types of the solid nodule, but normal tissue, and then there is a lump. So this is a form of hyperechoic nodule. Sometimes it's dark, sometimes it's very white. It depends on the color. And we biopsy this if it is more than a centimeter and above. We biopsy this to rule out malignancy. Or there is nodule that they are mixed. They have solid component and they have a cystic component. So they called mixed or complex cystic solid nodule. If it's more than a centimeter or 1.5 centimeter, we're biopsy. But if we are going to biopsy a complex nodule, we usually aim for the solid part, not the cystic part, because this one can be the cancer and the cystic usually blood and fluid. Okay, so that's the most important thing about the thyroid nodules. How do we approach a patient with a thyroid nodule? I see a nodule, patient is coming because they complain of a lump in their neck, or someone did incidental findings and imaging and they found a nodule in their thyroid. So if they have an imaging, it's already there. If they have, let's say, MRI of the cervical spine, so the MRI is not the best for the thyroid, then we need to do an ultrasound, because the ultrasound can differentiate between cystic and solid nodules. And the most thing important to help you, guide you for the workup of the thyroid nodule, it's the TSH. So first TSH. There is imaging, okay. If there is no ultrasound, go ahead and get an ultrasound. If the TSH is normal or elevated. So this patient either have normal, so means normal thyroid function, or elevated, there is sign of hypothyroidism. Then I go and see the ultrasound feature. If it meets the criteria of the FNA, like solid nodule more than a centimeter, then yes, we do the biopsy. If not, if like a cystic nodule, then we don't have to do biopsy. Here it comes the second part. If the TSH is suppressed, is a low TSH, what do I do next? Here it comes the role of nuclear scan. The role of this nuclear scan is I'm asking myself, is this nodule that we saw on ultrasound the cause of this low TSH? Is this nodule a toxic nodule causing low TSH? Then we do the nuclear scan. So the nuclear scan, if it's telling you that this nodule took up all the iodine and toxic and appears hot, we don't do biopsy because toxic nodules are not malignant most of the times, and even you cannot biopsy while it is toxic, you induce bleeding. But if the nuclear scan showing you cold nodule and the hyperthyroidism is due to other reason, Graves' disease or something else, then we do biopsy the cold nodule if it meets the FNA criteria. Is that clear? So the first thing is TSH subnormal means low. Yes, subnormal, below the normal, suppressed. Suppressed TSH means hyperthyroidism, at least primary, if you think of it. The second part after the TSH is a nuclear scan. So the main thing is by doing the TSH, it will help you either directly go for FNA or decide to do a nuclear scan. If it's normal or high, we biopsy if meets the criteria. If the TSH is low, we say, wait, let's do nuclear scan. If it's cold, we'll biopsy it. If it's hot, it's hot. It's like saying, don't biopsy me. Okay. And the reason for that is to rule out thyroid cancer. Oh, Ali, are you a radiologist? Talking about thyroids? That's too much. I'm not talking about thyroid. So tell us, Ali, what is thyroid? We take it in
Depending on the
surgery.
finding of the ultrasound, we have a probability of being cancerous or not cancerous. So we do
Okay.
FNA or not.
Okay, so you already got that. I'm not going to ask about these details, okay? But it's cyst, it's benign. The solid, if there is microcalcification and if there is feature of thyroid cancer, that increases the biopsy. But once it's solid, you have to biopsy it. This helps you more for the if it's mixed, because we have a lot of what's called a spongiform. They have a lot of cystic and a lot of solid. So which one we biopsy? Do we need sometimes? The solid is small and multiple cysts behind it, so it is small. So there, here it comes the thyroids. Well, I'm not expecting you to know this. Hyperechoic, that's by the ultrasound. Okay, the hypoechoic, this is hyper. The hypoechoic, it's a color between a black and between the hyper. So maybe let's show you something. This is maybe, no, this is on isoechoic. So isoechoic like الايكو اللي هو الايكو اللي طالع من الالتراساوند, and iso اللي nodule, it's the same color as the thyroid tissue. So this is the thyroid tissue and this is whiter than the thyroid tissue, so it's called hyperechoic. لا السيست مو hypoechoic, السيست anechoic, ما فيها echo, ما فيها أي echo cyst. Anechoic, black, completely black. It's called anechoic. Hypoechoic, a color between anechoic والisoechoic, gray, light gray. I'm not expecting you to know all of this. That's too much details. All right, that's the most important part. Don't biopsy something toxic. Don't biopsy something hot. Don't biopsy. Don't miss something. Don't go and do a nuclear scan for someone with TSH normal or high. Don't waste that. That's the main point. I do only nuclear scan for TSH is subnormal. Don't worry about the rest. All I want you to know, the approach, the process. Okay, we need the biopsy to rule out thyroid cancer. Histopathologic classification, so that's after we biopsy, after we take patient for surgery, we get different type of thyroid cancer. The most common ones are the differentiated thyroid carcinoma, and there are three different parts of the differentiated: papillary thyroid cancer, follicular thyroid cancer, and MTC, medullary thyroid cancer. Another part is poorly differentiated thyroid carcinoma, or even anaplastic, worse than the poorly differentiated, and thyroid lymphoma. So what is the differentiated thyroid cancer? I told you that we have three types: papillary, follicular, and medullary. These are differentiated. So papillary thyroid cancer, they come from the epithelial cell of the thyroid of follicular epithelial cells. It accounts from 70 to 80% of the cases. So the most common form of the DTC is papillary thyroid cancer, characterized on histology by samoma bodies, and it metastasizes through the lymphatic system. So the most area get involved and metastasis to is the adjacent lymph node. We always, when I see those patients, we have to do ultrasound and look for their lymph nodes. Fortunately, those patients, they have excellent prognosis. So they respond well to surgery. The second form, less common as papillary, but we still see it, is the follicular thyroid cancer. It comes again from the follicular epithelial cell, but it counts from 10 to 20%. It metastasizes through the blood vessel. So the lymph nodes are less likely to be involved in the follicular thyroid cancer. It goes to the blood vessel. And then if it's not treated, then it might go to the lungs and brain. Medullary thyroid cancer is the rare form of the differentiated thyroid cancer. It arises from the parafollicular cell. If you remember the parafollicular cell, the C cells. Do you remember what's the role of the C cells, the parafollicular cells? Lowers the calcium through calcitonin. So produce calcitonin, yes. So those patients, if I do a blood marker and I see elevated calcitonin, it increases suspicion for medullary thyroid cancer, and the calcium will be low. There is a strong family history of medullary thyroid cancer, and it's a part of a genetic syndrome called multiple endocrine neoplasia type 2. Those patients, if you diagnose one, you have to empirically, if the patient is tested positive for MAN genes, we take the thyroid prophylactically before they develop medullary thyroid cancer. Yes, they come with osteoporosis if the cancer is advanced. Yes, that's why even if the patient tested positive for MAN genes, like so if one part, we always call it this person saved the rest of their family. If one person diagnosed with medullary thyroid cancer, so they got diagnosed with a cancer, the other family member will need to get tested for MAN. If they have positive genes, take the thyroid immediately, even if the thyroid is normal, because likelihood to develop MTC over time. So we mentioned of the papillary thyroid cancer, it's characterized by samoma bodies. Samoma bodies is a round microscopic calcific collection on the histology. It's a dystrophic, is just part of calcification and necrotic cells, and they have this lamellated concentric calcified structure. So calcium and necrotic cell making a lamella together. This samoma bodies, you can see it on ultrasound as a microcalcification. So see, this patient has complex nodule, cystic and solid. The solid here hypoechoic. So this is hypoechoic. It's less echogenicity here than the normal thyroid tissue, and there is a whitish hyperechoic foci. So that's a microcalcification. So this entire will takes the thyroid high more than 4, increases the probability of papillary thyroid cancer. It has to be biopsied. What increases the risk of thyroid cancer? Radiation is the potential source, especially if it's used for medical uses of radiation, like in childhood malignancy. If I have a child or teenager coming to me with a thyroid nodule and there is a history of leukemia and radiation, or even brain tumor and history of radiation, I take that really highly suspicious for thyroid cancer. Again, what's going on? Atomic weapon, the illegal use of this nuclear power, like what happened in Japan. As you can see in Japan, they have a high risk of thyroid cancer due to exposure to atomic weapons in the past. The same thing that happened in Chernobyl, they have a plant accident from a nuclear power in the plant. I think this one was, I'm just saying because children, the most common cancer is leukemia, not necessarily leukemia. I'm saying the radiation. The radiation used for childhood malignancy increases the risk of thyroid cancer, not the leukemia itself. Or if they have brain tumor and they received radiation, okay, not the radiation as an X-ray, not the radiation for dental exam. No, the high dose radiation that's given in malignancy. Atomic weapon is the most dangerous one, and that's why now people in Ukraine, they worry about their thyroid and they go and get protective thyroid, and because of use of this atomic weapon can increases the risk, like what happened in Japan and Chernobyl. Again, and in the past, they used to do ionizing radiation for a benign. Now, radiation will only use it high dose for malignancy, but in the past, they used it to treat a benign condition in the head and neck. Do you know that in the past they used to treat acne with radiation? Because after they found that radiation heals everything, it's like, oh wow, they even tried it for benign condition. Not anymore now, because of the risk of thyroid cancer. Family history of thyroid cancer and mainly genetic, and the part of the thyroid cancer that's associated with genetic disorder is the medullary thyroid cancer as a part of multiple endocrine neoplasia type 2. I'll show you what is that MEN2 in a bit. Multiple endocrine neoplasia, it's 3 types. It's type 1, type 2A and B. Type 2 is associated with medullary thyroid cancer. A, they have history of, or they have parathyroid hyperplasia, and also they have history of pheochromocytoma. Type 2B, they have marfanoid feature, mucosal neuromas, and pheochromocytoma, but they don't have parathyroid hyperplasia. You don't have, yes, you don't have to know the details, but just I want to tell you that MTC is associated with genetic a disease called multiple endocrine neoplasia.
دكتورة
Yes,
أنت
go
قلتي
ahead.
إن البيشنت ياخذ ثيرويد از بروفلاكسس، طيب هل يحميه من الفينوكروموسيتوما مثلا والأشياء الثانية؟
شلون؟
أنت
شلون ما
قلتي
فهمت؟
إنه مثلاً لو في واحد بالعائلة اكتشفوه عنده مين، فهذا يصير بروفلاكتيف لكل الفاميلي، فهل بيسوي
Okay.
بروفلاكتيف الأشياء الثانية مثل الفينوكروموسيتوما ولا إذا أخذ
لا, you
اللي هو
cannot protect it for your chromocytoma. But some people, they may not have the MAN, they just have the medullary thyroid cancer. The pheochromocytoma can be managed, but the MTC is really bad disease. It's not the same management as the papillary and the follicular. Most of them, they end up need chemotherapy. So ما فيها prophylaxis. You cannot take the adrenal gland. And there is, you treat them once they have parathyroid hyperplasia. So far in Saudi, I haven't seen a case of MTC. Alhamdulillah, that's good. Clinical features of the malignancy, as any cancer, it's characterized by rapid growth, like goiter due to benign disease. They stay in size for a long time. Presence of or new onset of the hoarseness or vocal cord paralysis, fixation of the nodule to the surrounding tissue, and the presence of cervical lymphadenopathy, especially for the papillary thyroid cancer. How do we treat differentiated thyroid cancer, because I'm only covering the differentiated thyroid cancer, especially papillary and follicular, anaplastic and poorly differentiated. That's more advanced. We're not going to cover it. The main thing for thyroid cancer is total thyroidectomy. It's taking the whole thyroid out, and that's the primary mode of therapy. Unlike any other cancer, patient responded well to thyroidectomy, but still there is a risk of complication of surgery, although the surgery is necessary in this case. We just have to counsel the patient that these things might happen. Risk of injury to the parathyroid gland and presence of hypocalcemia, especially if the tumor is big enough to being attached to the capsule, attached to the parathyroid, and the surgeon had to take the parathyroid or injure the blood vessel of the parathyroid. Injury to the recurrent laryngeal nerve, tracheomalacia. I'm pretty sure that you went through this to surgery, or hematoma at the area. Adjuvant radioactive iodine therapy. So once they take the thyroid out, we give radioactive iodine, the same iodine we use for the Graves' disease, but in much higher doses in thyroid cancer. And the main thing of this is to reduce the risk of recurrence. It's not treatment, it's just to reduce the risk of recurrence and ablate any thyroid tissue left. Since we are using it with a higher dose, so there will be higher side effect, like salivary gland dysfunction, mainly they feel dryness of the mouth. It goes away over time. Present nausea and vomiting due to the metabolism of this iodine, and bone marrow suppression, especially if it's taken, patient had to take a very high dose. It suppresses the bone marrow, causes thrombocytopenia, pancytopenia, and anemia. And since our patient doesn't have a thyroid and we already gave them a radioactive iodine, they will be hypothyroid, iatrogenically induced by taking their thyroid out. We have to treat them with the levothyroxine, with the thyroid hormone, and to prevent the hypothyroidism and also minimize the TSH stimulation from tumor growth. We tend to give them higher dose than their body needs if they have a high risk tumor for recurrence. Lastly, we'll go over, we're not covering, I told you the poorly differentiated and anaplastic, but I want to tell you about thyroid lymphoma. So thyroid lymphoma is a history and the presentation of thyroid lymphoma that this patient has a pre-existing history of Hashimoto thyroiditis, chronic lymphocytic thyroiditis, but they presented with a very rapid growth of a diffuse goiter over time, even if they were well controlled. And you diagnose that by FNA of the thyroid and doing a flow cytometry to look for a lymphocyte. Treatment is merely taking the thyroid out and finished by chemotherapy, same as the lymphoma. So we don't do radioactive iodine and merely chemotherapy, as because this is a lymphoma. It's not papillary, it's not differentiated thyroid cancer. So the main risk is, or the alarm is a chronic, is Hashimoto thyroiditis and very rapid growth of diffuse goiter, rapid in days, yani 3-4 days or even at least a week, but not something that's been going on for a while, because everyone has, almost not everyone, majority of people, they have Hashimoto thyroiditis and they don't develop thyroid lymphoma. But if that happens, it raises suspicion for thyroid lymphoma. Okay, in summary, we've decided goiter into diffuse or nodular. Then we divided the thyroid nodule according to its structure or the function or histology. By the function, it can be toxic, hot nodule, or non-toxic cold nodule. And by the structure, it's a solid, cystic, or complex nodule according to the ultrasound features. By histology, it can be benign, it can be malignant. If it's malignant, it's either differentiated thyroid cancer, papillary, the most common, and then the follicular, then the medullary if it's genetic, anaplastic thyroid cancer, and lymphoma if it's very rapid growth and history of Hashimoto thyroiditis. That's it for this part. We have some cases to discuss, but if you have any question, let me know.